Welcome back, folks. Einstein's Eyes is fired back up. We had a bit of a hiatus, but we're back. John and I, so Carl Rosen here. How's it going? I'm an oculoplastic surgeon. I trained at Albert Einstein College of Medicine. I'm in Anchorage, Alaska now. Been doing this for quite a while. And my colleague, co-resident and friend, Jon Ditkoff, is going to introduce himself. John?
Hi, this is John. I'm living in northern New Jersey right now where my practice is. I do general ophthalmology and specialize in cornea and anterior segment. And Carl and I, as he said, train together. And it's nice to be able to get to see him once in a while through this great cast.
Yeah, absolutely. It's good to see you too, John. So we're going to talk about ptosis. Ptosis is a droopy eyelid, and I'm going to show you guys that right now. So as you can see, here's an eye that has a droopy upper lid and a normal upper lid. And we break ptosis up really into two categories, into kids and adults. And I'm mostly an adult ptosis surgeon. Ptosis is a weird name. I mean, Ptosis. Why can't you just say droopy eyelid? I don't know. I don't have an explanation, but this is how it is.
Why is the P silent? That's even stranger.
I know, right? Right? Ptosis, yeah. So we'll have to dig that up. But ptosis, the big problem with ptosis is that it obstructs the upper part of your vision. And weirdly enough, it makes reading difficult. And it seems counterintuitive, but that's what happens. There are two muscles in the eyelid. One is called the levator muscle, one is called Mueller's. And oculoplastic specialists manipulate one or the other. You come from an outside approach with the external levator approach, or you go something called a Muellerectomy or an internal ptosis repair from underneath the eyelid. I like that approach a little better. It's a little more predictable. It takes about 15 minutes. The external approach is also good. It takes a little longer. Most of the times it is related just to aging, just aging effects. Now, sometimes it's a problem. You know, sometimes it could be a nerve issue. It could be from a stroke. It could be from something called myasthenia gravis. It could be something called Horner syndrome. That's a bigger deal. We won't touch on that. But if you have a small pupil and ptosis, definitely get it checked out by an ophthalmologist or a neurologist. Now, as I mentioned, there are surgical approaches and there's non-surgical approaches. There's a new medicine called Upneek. I've never used it. Optometry likes it. You got to use it every day. I really can't comment on that, but I just want to let you know it's out there. And really, what I tell folks is, look, it'll take about 15 minutes. Takes you're bruised, you're swollen for about 2 weeks. Sometimes we have to do a revision or a re-op. Most of the time you don't. Most people are happy, or at least better. The one thing I don't like is aspirin or anticoagulants before surgery. That can really mess up a surgery, and it can break the stitches that I put into the muscle to hold it up. And that's ptosis in a nutshell. John, any comments on that?
Yeah, I would add just a couple of things. As you said, before doing surgery, we're going to rule out all those neurological issues. So, I mean, most of the time it's going to be obvious it's age-related, it's bilateral, but if it's fluctuating, if it's one eye, then just to be safe, we might do some testing just to make sure it's not one of those things before you do surgery.
Right.
Also, the Upneek I have used. I've had pretty good results with it. It's nice to, if a patient is kind of on the fence whether or not their symptoms are coming from the eyelid, we might have them use it for a little while just to see how they like it. And when they appreciate the difference, it's not really a great long-term treatment, but it's short-term. It's kind of nice. Then they say, okay, yeah, I definitely want surgery.
Yeah, no, I think that's reasonable.
But we don't use it often. Yeah, I mean, I think it's a relatively successful procedure. Like anything, it has some risks. You'd be the expert when it comes to that. But I think the biggest risk, I guess, in my experience, is just the fact that if you do bilateral or even if you do one eye, the odds that you get it exactly symmetric is low. I mean, like you can get it very close, but patients have to be realistic. One eyelid might end up being slightly higher or slightly lower than the other one.
Yeah, no, I never tell people I'm going to get it exactly perfect. No,
Exactly.
you got to have realistic expectations here. Yeah, no, brilliant. I think that's it in a nutshell. Really good to be back, John. Great seeing you.
Yeah.
And so, folks, we're gonna have more videos coming, and we really appreciate you being here. It's great to talk about ophthalmologic topics and subjects, even if it doesn't make sense. Ptosis again, silent P. What the heck? Anyway, folks, we'll see you soon. Okay, thanks.
I enjoy it.